Today we've got a topic that is very, very timely, and it's something that is changing over time. And to discuss it with me are Justin Palmer, the Vice President for Public Policy and External Relations at the District of Columbia Hospital Association, and Mark Kennedy, who's the Vice President of Legal Affairs at the Physicians Committee. What I'd like to do, if I may, is to just start with some background about where we are in the pandemic. And I'm going to show a number of images. And if the little photo strip on the right-hand side of your screen is in the way, you can just drag it to the side or minimize it. It's not your imagination. The pandemic is waning here in the United States. We got a couple hundred deaths every day, which is terrible still, but far better than where we were earlier this calendar year. Globally, it's a different story that's driven by the fact that in some countries they're doing much better and other countries doing much worse. In India, case in point, things were terrible in May, but have quieted down a great deal. And that is the Delta variant. I'll have more to say about that in just a second. The key point that's really driving this discussion is that viruses don't live outside of a body. They need a host. They're always seeking new hosts, whether it's a new person or a new species. And when they encounter a new host, that host has defenses. And so they mutate to overcome those defenses. So the whole raison d'etre of a virus is to figure out how to survive by mutating, by changing, by overcoming our defenses. And those defenses can be natural defenses or they can be vaccines. In the US, as you know, we've got 3 vaccines: the Pfizer vaccine, the Moderna vaccine, the Janssen vaccine, all widely used. And as of last week, not quite half of the US population was vaccinated. If you look at adults, anybody over 18, it was more than half. And if you look at adults over 65, it's almost 80%. And going up at a somewhat slower pace now than it was before. All pharmaceuticals have side effects, including vaccines. Fortunately, most side effects of the vaccines are mild and they are familiar to people who are involved in vaccines: swelling, fever, headache, feeling kind of crummy for the day or two after you got the vaccine. However, there are serious side effects too. Luckily, they are very rare, but there are 3 that I want to just mention briefly. One is anaphylaxis, usually predictable, but it occurs in 2 to 5 cases out of every 1 million doses used. And this is why after you have a shot, they'll say, don't leave, sit here for 15 minutes and then you leave. More serious, thrombosis with thrombocytopenia syndrome. This is with the Janssen vaccine. And as of late June, there were 36 cases reported. Now, out of 12 million doses, that means the risk had been about 3 per million. And myocarditis and pericarditis have been reported both with Pfizer and Moderna, and there it's roughly 1 in 1 million cases. So these are serious, but they're luckily very, very rare. We're not seeing anything like the Guillain-Barré syndrome scare that we had with the H1N1 a number of decades ago. So then the question is, does the vaccine not just protect the vaccinated person, but will it reduce transmission? Because in our clinic, that's what we're thinking about. Will my staff risk giving COVID to my patients? And some really useful data came from 2 studies that I want to share with you. These just came out in JAMA. This is from Tel Aviv and reported last week. They looked at healthcare workers who were unvaccinated or fully vaccinated. The tan lines that you see here are unvaccinated healthcare workers. And they were tracked over time after the doses were available. Some did not get vaccinated. The heavy line is the unvaccinated people who had symptomatic infections, and this is a cumulative graph, so it goes up and up and up. The dotted line, these are the asymptomatic infections in people who were not vaccinated. And the blue lines are the vaccinated people. And what you can see is that the vaccination doesn't just reduce symptomatic cases. It reduces asymptomatic cases. And those are the ones that in the healthcare facility we're thinking about. The person who doesn't know they've got the virus, they're carrying it in, and they are transmitting it to other people. The vaccine does seem to reduce both. By the way, this was Pfizer that they were using. At St. Jude Children's Hospital, they did a very similar study. They looked at unvaccinated people, unvaccinated healthcare workers, followed for 81 days. And in those 81 days of the unvaccinated people, there were 185 positives, and 79 of them were asymptomatic. They compared them to vaccinated workers. People had at least one dose. They had 3,000 people like that. Not quite as many had both doses. And over a 72-day observational period, 51 positives, 29 were asymptomatic. However, if you cone down to those who had both doses, you had only 10 total positives at all. So what we really have to conclude is that vaccination does reduce asymptomatic harboring of the virus. Okay, so the headline nowadays, of course, is variants. The Alpha variant out of the UK, the Beta variant out of South Africa. Then there have been a number of others, but the one that's everyone is concerned about now is Delta, which started out in India. What's different about it is not so much its pathogenicity as its transmissibility. It's really easily transmissible. And that's what we're seeing right now in the US. As of in the 2 weeks before June 20th, here in the US, about 30% of the cases were Delta. As of end of last week, Saturday, it was about 52%. That's going to go up, 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 up. So this will be the dominant. It's already the dominant variant. It's going to be more so. But almost entirely among unvaccinated people. You've been seeing the headlines that came out of Israel, which is that the vaccines are less useful against Delta. Maybe, maybe not. The vaccine that has been used in Israel, 64% effective against infection. That's not so great. That's 36% not effective. But when you look at severe disease, it looks like against the Delta variant, we're about as good as we were with the original coronavirus, 93% effective against severe disease. Not perfect, but still really quite good. So the conclusions are, my conclusions are, that vaccination of healthcare workers is going to reduce viral transmission, because it not only reduces symptomatic infection, it reduces asymptomatic infections that people come in with. The most important thing, though, to remember is that healthcare workers are masked. And so continued spread is more likely among unvaccinated workers, even if they're masked. In the study I showed you out of Israel, showing that there were asymptomatic and symptomatic infections among unvaccinated people, those were healthcare workers. They were careful, they were washing their hands, and they were masked, at least in the same way that healthcare workers are. There are serious adverse effects. They are real, but they are luckily quite rare. To finish up, let me just talk about what has been happening at Houston Methodist. All employees are to be vaccinated. That's their policy. There are exemptions for medical contraindications and for sincerely held religious beliefs. As of May 20, or on May 28th, employees filed suit. And they were saying, I don't need to have a religious exemption. I don't want to be forced to do this. I don't need a medical exemption. I don't want to be forced. As of June 7th, about 25,000 workers had been vaccinated and 178 had not. They were threatened with termination. 25 of them then were vaccinated. The other 153 were in fact terminated. The case went to court. The employee lawsuit was dismissed. It could be appealed, but that's kind of where we are. Okay, things are moving on this landscape. Let me turn it over to Justin Palmer, Vice President for Public Policy and External Relations at the DC Hospital Association. Justin, over to you, please. And let me ask everybody to please mute. If you have a question, you can put it in the chat and I will do my best to relay those. And then eventually we can, of course, open it up to doing this verbally if we like. Okay, Justin, over to you.
Yeah, absolutely. Thank you, Dr. Barnard. I'll be brief and then happy to take questions as we're going through this. As it's been widely reported, the District of Columbia Hospital Association's Board of Directors adopted a policy moving to mandatory vaccination for employees based on the science, based on the availability of the information, and what is best for the employees and for the patients that we care for. And that was really the driver for this. When we look at, we are not prescribing policies for the hospitals. Each hospital will identify their own policies, how they implement, what the, around it, and set their own timeline for doing it. 2 hospitals have set timelines. Others may wait until the EUA is lifted and it goes to full approval. And that's really, as we've been looking through that, really an important part of the process. We are encouraging hospitals, as they adopt policies, set timelines, to have a communication plan, education plan. This is not a one-time discussion. This is not a memo. This is a continued discussion with employees, as has been since vaccination started in December, of healthcare workers, making sure that we share facts. They'll set the scope of policies of how they implement. Houston Methodist started with managers and then went from there. And there are will be exemptions for medical conditions and religious beliefs. But as we look at look at the workforce in the hospitals, about 70% of hospitals in the district are vaccinated at this time, and really working towards that, getting to the full vaccination is the aim. Hospitals continue to do that individual education. They've done rounds. They're doing town halls throughout this whole process in order to make sure that they answer the questions for their employees and those that are affected, to encourage the vaccination. There are pockets of hesitancy that we continue to work on, and that is the goal as we move forward. I will say, since this is released, we have not had negative. There hasn't been a groundswell, and it's pretty much been a status quo of how things are going. I will also say vaccination is not new, or health. Flu shot is mandatory within hospitals and has been for quite some time. So as we look at the policies, I feel more comfortable answering questions about how what questions you have, but that's kind of the summary of what we've done. I will say Maryland and DC went on the same day. I believe several states, Pennsylvania and Connecticut, have issued consensus for the hospital associations as well. So at this point, so that's my 5 minutes.
Nicely done, Justin. Thank you so much. Let me bring in Mark Kennedy. Mark Kennedy is the Vice President of Legal Affairs at the Physicians Committee for Responsible Medicine, and also dealing with Barnard Medical Center. Mark, jump in.
Sure. Thanks, Dr. Barnard. I am going to hopefully quickly share my screen. All right. And okay. Is this on screen? Someone give me a thumbs up, Neil. Excellent. Okay, well, I found it interesting that 70% so far of our hospital workers, as of the announcement in June for the DC Hospital Association, were vaccinated. I would have expected it to be more, and maybe we are moving in that direction. So I'm going to start with a general view first. How must medical practices protect employees from infectious illnesses in general? Now, most of these, let's see here. Yes, employees. Most of the requirements in this regard flow from the Occupational Safety and Health Act, which is a law administered by the Occupational Safety and Health Administration. And these are laws that are designed to protect employees in all settings. For healthcare workers, there is a requirement that all employees must have access to protective equipment like masks or whatever else would be appropriate for their job. And then there's something called the general duty clause that applies across the board to all employment settings. It just says that employers must provide a safe work setting that is free of hazards that likely to cause harm or death. You know, some obvious stuff. So that's where we start from a safety standpoint for employees in the workplace. How must medical practices protect patients from infectious illnesses? Well, there are a number of different standards, but the most important guidance comes from the Centers for Disease Control and Prevention. And on that website, there are recommendations that employees be vaccinated for things: hepatitis B, chickenpox, flu, mumps, measles, and so on. And the CDC's website also has this very handy tool that allows you to see what states require in this regard. So you can select your vaccine and your state, and you can see what kind of workers that it applies to. And, you know, for instance, and as Justin mentioned, 17 states require all of their, 17 states require hospitals to at least offer the flu vaccine to employees. And then 2 of those states require the employees to take it. And then, of course, hospitals can set their own policies as well. That's kind of the general view. There are other state and local standards that apply, but the CDC is really the place for patient care. You're obviously familiar with other laws that do apply to patient care, things that relate to privacy, billing, you know, HIPAA, the anti-kickback statute, Stark, things that are federally oriented, but not related to care. That's where the CDC comes in. How must practices protect their employees from COVID-19 specifically? So same slide, different subject matter. At the federal level, returning again to OSHA, there is a recently issued standard. It's called the healthcare, it's called an emergency temporary standard, and it pertains to COVID healthcare settings. And it imposes a number of requirements on a variety of healthcare providers' facilities, hospitals and ambulatory care and nursing homes and the like, but all the way down the line to smaller places as well. And it says that in these settings, employers must develop a COVID plan, so something that shows that they're addressing the pandemic. There are requirements related to ventilation. There are requirements related to disinfecting and cleaning, barriers, social distancing, masks, and so on. Some of the requirements are fairly onerous, but if your staff are fully vaccinated, they are exempted in certain settings from the requirements related to barriers, distancing, and masks. So what you're seeing here is a federal incentivization program, basically trying to get people vaccinated. Although nobody is mandating it at the federal level, you stand to escape many burdens and perhaps some costs, as well as increase your patient and employee sort of care if you follow these and get vaccinated. How must medical practices protect patients from COVID-19? We see a lot of variation around the country. The CDC recommends masks and screening upon entry of patients and others. In Washington, D.C., there are quite a few mandatory requirements that are being issued by the D.C. Department of Health via, they flow from mayor's orders, and our mayor has been updating them all along. But in D.C., it is still required in medical settings that patients, practitioners wear masks, that there be screening upon entry, and that there be notification to the DC government and to others depending on exposures in the workplace, depending on the severity of the exposures in the workplace. In Maryland, it is still required to wear a mask if you're a medical provider, and in Virginia, the language I have found says should, but it is being advertised as a must. So things vary a little bit. So here's what we're really talking about. May a medical practice have a mandatory COVID-19 vaccine policy? And the answer is yes. The U.S. Equal Employment Opportunity Commission says, yes, employers are permitted to do this. It does not violate any laws as long as you follow Title VII of the Civil Rights Act of 1964, as well as the Americans with Disabilities Act. These are two laws that anybody who works in the HR department is familiar with already. And they basically require an employer to consider reasonable accommodations upon request from certain groups of people. So in the context of Title VII, this is a law that prohibits discrimination on the basis of religion, race, and several other factors. And so here, when we're talking about a vaccine policy, we would have to consider a request to honor somebody's sincerely held belief that taking a vaccine would interfere with their religious practice. In the American with Disabilities Act context, the right to a reasonable accommodation would flow from a medical condition or disability. So it may not be a disability per se, because the act covers things like pregnancy and how this might affect your ability to take a vaccine. And you may have a compromised immune system. So there are a number of factors that would play into this. Both laws apply to employers with 15 or more employees. That is the federal rule. But in Washington, D.C., the D.C. Human Rights Act actually lowers that so that it applies across the board. If you are an employer in Washington, D.C., if you have at least one employee, you are going to have to follow these rules. Maryland still sticks to the 15, and in Virginia, there's a baseline 15 employee standard, but then it adjusts ever so slightly to 5 in certain settings. So the moral of the story is that you should be prepared to respond to requests for reasonable accommodations under either law. Now, how does it work? Well, under the analysis is slightly different under each law, and I'll start with the hardest one first, the Americans with Disabilities Act. When you have a qualification that all employees must meet, somebody who is unable to meet that because of a medical condition covered by the act is not required to meet your requirements unless they pose a direct threat to safety. And that could be the safety of others, such as patients. It could be the safeties of their colleagues, other employees. It could be even their own safety. So if there is a direct threat, as would be the case in the context of an infectious disease that is harming and killing millions, we would probably say, well, there is a direct threat here. So the next step would be, having recognized that there's a direct threat, is there a reasonable accommodation that might address that for this employee? And it's a very fact-specific, circumstance-specific analysis, and you would want to bring in legal counsel if you have it. But basically, you would look at the person's role and what kind of exposure is involved. Now, if you have somebody who comes into the office and works on a different floor from where there is patient care, a mask or barriers or something else might do the trick. If you have direct contact with patients on a regular basis, it's a very different analysis. So you determine whether there is a reasonable accommodation. And like I said, it could be that somebody sits on a different floor, or it may be that for the duration of the pandemic, they switch to a slightly different role. Maybe they don't have patient care or patient contact. There are a number of different ways to do it. But the important thing is that under Title VII and under the ADA, an employer is not required to provide an accommodation if it provides what is called an undue hardship to the employer. And that term is defined slightly differently under both acts. Under the ADA, it's something that would cause a significant cost for the employer. Under Title VII, which is where your religious exemption requests might arise, it's just more than a minimal cost. Nevertheless, you want to keep all of this in mind, and I think it's safest to just, as much as possible, use the ADA's analysis. I mentioned the phrase direct threat. It's defined in the regulations. It sounds in some sense very dangerous. But basically, it is something that could cause harm to a person, and absent significant adjustments to prevent it. So that's kind of the context here. One thing to consider with any policy is that, especially under the Title VII context, there are going to be certain populations, certain groups who may not have had as much access to the vaccine. So you want to be conscious of the possibility that your policy is affecting one group more than others. In the legal context, we call that disparate impact. You may have heard it before, but you would just want to make sure you're being thoughtful and aware. And then most importantly, in any HR matter, is consistent application of a policy. What kind of documentation may or should you request? First off, it is somewhat of a medical inquiry, asking somebody if they have a vaccine. However, it is not something that, let me rephrase that. You may ask your employees to provide evidence that they have been vaccinated. You may even ask whether they have been vaccinated. That's fine. That doesn't trigger any laws, but you wouldn't want to ask too many questions, because you may venture into other territories, such as the territory covered by the Americans with Disability Act. Speaking of which, if somebody says to you that they do have a medical condition that prevents them from taking the vaccine, that is when you can ask for other information. You could ask for a medical record, a letter from their doctor saying what exactly is their condition and what accommodation does the doctor think is appropriate. This is an inquiry, again, that any HR department should be familiar with. Under Title VII, when we're talking about religious exemptions, most of the guidance online says don't do more than maybe ask. I mean, most of the time if somebody says, I have a sincerely held religious belief, it's better to just accept it. But you could ask for some sort of documentation, just maybe a statement from the employee that says, here's my belief and why this is important. That's a documentation. So how is this playing out in court? Well, one thing to consider is that when you have a vaccine policy that is mandatory like this, and an employee gets a vaccination because of your policy, any adverse reaction that the employee has to the vaccine is considered a work-related injury. So it's something that OSHA cares about. It can give rise to liability. But continuing the theme of the federal government incentivizing vaccination right now, the OSHA standard that applies to that would require an employer to do something about an adverse event related to a vaccine and maybe even report it to OSHA, that regulation has been relaxed through 2022. So we're in a time when the OSHA agency is recognizing that it's appropriate to require vaccination. But what is happening in court in general? Well, we've seen cases against a sheriff, against a school district, and in other settings. Dr. Barnard mentioned the Houston Methodist case. And then we see some states taking legislative action. So in Montana, there's been a law that bars employers from requiring vaccination as a requirement for employment. I'm going to touch on the Houston Methodist case because it's particularly important, and right now the only one that I've seen in the medical context. Those others were other employers. So here's some text from the policy that Houston Methodist issued on March 1st. And Dr. Barnard touched on the policy a little bit. It applied 100% to all employees, and it went off in two ways. First was for management, so they could be setting a good example. Second was for everybody else. And there were 2 weeks in which to take care of your first dose, and then 2 more weeks in which to wrap up the entire process. And if you didn't do that, and if you didn't have an exemption under either Title VII or the ADA, you basically were risking your job. And so 117 employees filed this lawsuit. And they raised a number of interesting arguments. One was that this violated Texas law on employer-employee relations. One was that the requirement for vaccination basically was along the lines of a requirement that people enter involuntarily into a clinical research program. Another argument advanced related to international law and the idea that it violated the Nuremberg Treaty. The judge who handled this case basically across the board dismissed all of them and citing public policy in favor of vaccination, citing the EEOC, the sources I mentioned earlier, and also citing two very old Supreme Court cases from the early 1900s recognizing the importance of vaccination and quarantine in different contexts. So it was a very short and strong opinion that dispensed with the case. It is on appeal now, so we will be watching that. Now, I know I said a lot here, and there is a lot of information online. For me, in researching this and taking a close look at what happens in Washington, D.C., these were some of the best sources here I have on the screen. The EEOC guidance that I've mentioned a few times talks a lot about accommodations, undue burdens, the direct threat standard, all in the context of COVID. So it is very helpful. If this is a link that you might be interested in, please copy it down, especially if you don't have an HR department or counsel you can consult with. The DC health guidance is interesting. It evolves from week to week. As I said earlier, it flows from the mayor's order, who basically, she instructed the DC Department of Health to issue guidance specific to different industries. And there are a few different issuances on this link here, the coronavirus.dc.gov, that are specific to healthcare. And then the emergency temporary standard I mentioned earlier, also for OSHA. This is something you should take a look at, especially if you work in a large health facility, to make sure you're following all of that. There are online, this is now the bottom there, the Society for Human Resource Management and LexisNexis and many law firms just have posted online sample policies that you can adjust depending on your circumstances. The ones I have seen, samples or not, always explicitly mention the religious and medical condition exemptions. That's a good idea. You don't have to because they're implicit in labor law, but it's a good thing to do anyway when drafting your policy. But at all stages of this, it is always good if you have legal counsel to consult with them. And I think that wraps up. I know I said a lot, but I think that's all for me for now.
Thank you so much, Mark. Excellent presentation. Let me finish up with a few comments, and then if you have a question, please type it in the chat box. I think that'd be a good place. That's where we'll start. Let me comment about what we're doing at the Physicians Committee and also at the Barnard Medical Center. And let me contrast it with the situation in Houston. Mark showed a slide of Houston's viewpoint, which I take to mean that they're there not just to protect their workers or to protect their patients, but they see themselves as part of an effort to protect the community or the world against the advancing virus, if I'm reading this correctly. We've got the vaccine, let's use it, let's have doctors be role models, let's all get vaccinated so that the public in turn will get vaccinated. That's a reasonable viewpoint in my view, but that's not the viewpoint that has driven our policies when our patients come in. We're driven by the policy of first do no harm, that the patient comes in, we don't want to give them an infection. And if there's anything that we can do to prevent that from happening, we will do it. And so what that means is that overall, while in Houston, and in DC, if I understand the policy correctly, Justin, hospitals are really going to require that everybody be vaccinated. We haven't gone that far to say that all of our employees need to be vaccinated. However, in another sense, we're going further, and that is if you are an employee who has patient contact, you're the medical assistant who's taken a blood pressure. In that case, you must be vaccinated. And moreover, there is no exemption of any kind. It fits in with what Mark was describing as presenting a threat to a patient, which we just can't justify. In other words, could somebody else take that blood pressure who's vaccinated? Obviously, so we don't put the patient at risk. A person might say, well, then you accommodate me. We could legally say we won't do that. However, what we do is we say we'll accommodate you with a job that doesn't involve direct patient contact. End of story. So let's see, what else did I want to tell you? Oh, I should mention that some people might describe what their reason is for declining a vaccine. We don't care. We don't ask for that and we don't inquire. If it's a medical issue or a religious issue, we don't inquire at all. If a person is not vaccinated, they're welcome to continue their work. But if it's patient contact, they are absolutely not able to do those functions that involve patient care. Will that lead to some people being concerned? Obviously, no question about it. But my own view as a physician is when you become a physician, your protection of the patients trumps everything else. That's it. There's no argument. There's no debate. I don't care what you believe religiously, or I don't care what health conditions you may have had. You can't have contact with that patient if it puts the patient at risk that I can otherwise prevent. So that's where we are. Let me come to questions. I noticed one question that whizzed by was somebody was asking, which religions are we talking about? They're actually not, to my knowledge, any major religions that oppose vaccination as a blanket policy. Probably the best known is Christian Science, where they generally discourage use of medications, the use of vaccinations, and so forth. And there are some others, less known, smaller, that have similar guidance. There are some religious concerns about animal-derived vaccine components, none of which apply to any of the vaccines that are legal in the US. They are all free of those components. There are some religions that encourage vaccination because they view it as for the moral good. Let's see. Justin, let me bring you in to this. Somebody asked the question, what if a person declines to be vaccinated? According to, if I understand right, the DC Hospital Association is saying, okay, hospitals, you got to require it, but you are going to allow exemptions. And if a person does want to take advantage of that, is there something else that they should be doing? For example, in addition to masking, should they be doing frequent testing? Or is there anything else that you're recommending?
So those are good questions, and those are considerations as in our case, hospitals or practices are implementing policies on building out what are the things that need to be put in place to protect the patient, protect the staff members. As Mark outlined, the guidance in DC for healthcare facilities and healthcare workers is pretty extensive. And so, masking, the face shields and things like that are all strategies for mitigation with using PPE. I think, from other policies that I've heard, I can't speak to specifically to any DC policies, testing and monitoring are part of what others have done. As Mark mentioned, screening is still required for healthcare facilities in the district for patients and staff. It may not have to be active, but passive, as long as there are documentation. So I think those are all parts that are going to have to be developed. As our position is, the hospitals are going to adopt and create policies that work for them and work for their. And so I think you'll see variation. This is not going to be a blanket policy across all facilities. So it's not going to be the same wording, and that's going to be one of the things that as this moves forward, that we have to deal to tackle. I will also say part of what has gone into the work and the strategy is that protecting, particularly patients, particularly pediatric patients that aren't eligible for the vaccine yet, is one of the driving factors for vaccinating healthcare workers as well, particularly for pediatric focused practice. So.
Let me make sure I understand what you're saying, Justin. You're saying that because the children are not going to be vaccinated, they're not eligible for vaccination in many cases, it's the responsibility of the worker to do what they can to minimize transmission?
I think that's some of the thought process that's going through some of our members. Yes, is, especially those patients that are under 12 aren't eligible to be vaccinated at this time, and so making sure if they're in a healthcare setting, making sure that they're protected as much as possible.
There's another question says that many I guess physicians hail from communities already skeptical of healthcare interventions. And if I'm reading the question correctly, it's that there is a certain amount of vaccine hesitancy, and how should that be addressed? Let me see if our panelists have a comment on that. Before I do, let me suggest that I think that in some ways, in our zeal to promote vaccination, both as a medical community and also as a society and the media, in some ways, I think we've gone almost too far. And let me hasten to explain what I mean. Vaccines are clearly life-saving, but in some cases, the verbiage that's used sounds almost like we're cheerleading and saying, everybody's got to get a vaccine. They are so safe, there's nothing to worry about. My own sense is that it's more useful as a doctor to clearly explain the benefits and risks, to not deny that there are some risks, but then put it in perspective and say that the benefits are X and the risks are Y. And to my reading, the equation comes out very, very strongly in favor of healthcare workers going ahead and being vaccinated. Others may not have that view. My concern is that when we push so hard for vaccination and say that it's safe and everyone should do it and there's no risks, in some ways I fear that we're engendering some skepticism that might not otherwise be there. But let me ask the panelists, do you see ways that skeptical populations can be reached, encouraged to take advantage of vaccination? Justin, let me start with you.
Yeah, our members have been tackling this question since before the vaccines were approved, and how we have the discussions. Our members have done a variety of education, peer-to-peer champions, leadership, leading by example, and having those discussions. But I think an important part is having the discussion and understanding, what an individual, what questions an individual has. And one of our CEOs talks about this a lot of, any question that someone has is worth, hearing out to have a better understanding of what they need to feel comfortable with the vaccine. And I think that's those are some of the strategies that our members have and continue to employ in order to address the hesitancy issue across some of their employees. And obviously there's more work that needs to be done, and it does continue to be carried out.
Mark, would you like to jump in on that, the question of hesitancy, and is there a way to deal with this? Because I guess we're talking about is not just perhaps in the public sector, but also within a workplace. That's what we saw in Houston, and I think we're going to see that everywhere, and I think one would expect that. Mark, do you want to jump in on that?
For me, just as more like a personal tale, but when I have gone to any doctor, including a specialist who's completely unrelated to my day-to-day health, that's one of the very first questions I get. Did you get the vaccine? And it's not even necessarily something that applies in the context of that visit. And I think it's interesting, and that just makes it sound normal, makes it sound expected. And I think that if everybody does, obviously you're not going to do that to your colleague in the workplace, perhaps, especially if you're not in a medical setting. But doctors, if they're asking that of their patients, no matter what, even a foot doctor, just ask, see what happens. I think that normalizes it. I think there's there's still some room for federal and local governments to encourage it more. I was frankly appalled at the lack of encouraging language on some of the websites I'd seen in cases in which state governments or even the CDC have started relaxing standards, but not simultaneously still encouraging things that are good behavior and good for safety. And that's more of a personal opinion, but I was surprised at what I saw on the CDC's website while preparing for this.
Very good. I see a question about why doesn't the medical community recognize natural antibodies? If I'm understanding that question, the idea is you had the disease, you had COVID, you're now immune. Isn't that good enough? Justin, is that something that came in as you were formulating the policy? Let's say you've got hospital workers at GW, Howard, Georgetown, Sibley. They've had the virus. Can they be an exception with regard to getting the vaccine?
That has not been part of the discussion that the hospitals have about the natural antibodies. I think one of the questions is, this is not part of the policy, but that we've seen is how long those antibodies last for an individual versus what the protections that the vaccines provide. And so I don't anticipate that being an exemption from the policies, but that'll be up to the individual hospitals and hasn't been part of the discussion.
Yeah, I think what you said is right. I think the hospitals are leaning toward not making that an exemption for two reasons. One is nobody has any idea yet how long that immunity, if there is any, lasts. And secondly, in the face of variants, including variants to come, I think most people are not feeling super optimistic that having had COVID before is much better than having had the flu before. You had the flu last year. That's not likely a lot of protection from getting it next year. That said, I think it illustrates an important point that I think underscores this whole thing. When you've been describing the DC Hospital Association guidelines, Justin, or Mark, and you were discussing the national policies, or what I mentioned at BMC, all of these things are in the context of a pandemic that is changing week by week by week by week. And I think that we would almost certainly revise all of these things in the event that the pandemic really does wane in a much more convincing way than it has now, or if it heats up with new viruses, new viral variants. I think it's going to change things. So everything we're saying now is being written in pencil, not really being written in pen. Let me see. We have time for just a couple of more questions, if I can sort these out. The question is, if I understand it, have large healthcare hospital systems entered into this debate? Obviously, we talked about Houston, which is enormous. But do we know anything about the government? The military, to my knowledge, has not yet made a requirement, but if you know better, let me know. Or the Indian Health Service. Mark or Justin, do you have information on those entities?
I can, since the DC VA is a member, while there's support for the policy, the VA has not adopted a system-wide approach. And any approach, my understanding from the VA would be, any mandate would be a system-wide. So the VA, even the DC VA at this time, is not implementing the mandate at this time. So they're waiting for a national resolution.
I'm kind of wondering why that was. When maybe 8 weeks ago, the reason that they weren't enacting mandates was that the vaccines were everyone was saying, well, they're not FDA approved. They're just on emergency use authorizations. But as they move through the approval process and you have approved vaccines, everyone really expects that the big chains are all going to get on and require it just like they require, as you said, flu vaccines and so forth. So I'm guessing that may happen.
My understanding is I think the VA made flu mandatory for the first time last year to various. So I don't know what their timeline would be.
Okay. All right. Very good. All right. If there are no further questions, I would just like to say thank you to our panelists. Thank you, Justin. Thank you, Mark. Thanks also to Pia and to Robert Hay at the Medical Society of DC for bringing this forward. And thanks to all of you for participating today. Thanks very much. Have a good evening.